Well, I work in Minneapolis, Minnesota. We are one of the 5 polytrauma regional centers, which covers primarily the upper Midwest. We have an inpatient facility with severe TBI, emerging consciousness, a separate very large facility for dealing with spinal cord injuries, which also includes multiple sclerosis and other kinds of demyelinating diseases that may affect ambulation, and a big amputation service as well. All of the multi-system care that needs to be delivered at the PRC. We also have a step-down unit, which we call PTRIP, or the Post-Traumatic Reintegration Program, which allows patients to begin to live independently while they are still able to attend therapies and be under the supervision of nursing services, but they live in little apartments within the hospital and act independently. They have to do their own meds, attend their own appointments, and they just generally get used to being out back into real life. We also have a visor program, low vision, and within the last year or so, we've been able to use some of the beds in the PRC to house patients that are attending our what we call HOPTEL, which is a kind of a mini blind rehab boot camp where they come for 4 days and get intensive training in low vision. And that has been really good because they're now all within this unfortunately very, very large building. But before that, they were off-site and had to cross the street, railroad tracks, and a variety of other unsafe things that this has been a big improvement. So all of the patients in the PRC, as we learned from Dr. Rakowski, are supervised by physiatry with multiple therapists and consultants, and in our case, we have both ophthalmology and optometry. I see the majority of the inpatients, and our optometrist sees the majority of the outpatients, but we kind of trade back and forth so that we always have pretty good coverage. Unlike Tampa, we do not have an OT that is providing the vision therapy. We have a BROS. She's very well qualified, and she acts as a liaison between the different therapists. She does co-treatment. She arranges schedules. She goes to all the rounds. She's an active member of the team, and she really keeps tabs on everybody. She does home visits. So we would like to have many more of her, but so far we just have one. RVA is a teaching hospital. It's associated with the University of Minnesota. We do also have residents from the Mayo Clinic. We now also have optometry residents, and they are rotating into polytrauma and low vision, so we hopefully will be able to increase the number of optometrists who have some polytrauma experience. We also have arrangement with a local university, St. Catherine's University, that is training JCAPO patients to become certified ophthalmic technicians and orthoptists, and they work in the eye clinic as well. One of our problems is that the eye clinic is one of the busiest services in the hospital, and we have always a packed waiting room. So one of the first things that I did is to set aside a little room at the end of the hall, and as soon as the people walk in, they are whisked into the room and away from everybody else, and we try to keep them segregated that way. And I have a tech who is a very soft-spoken, kind individual who helps them to feel more at home. As you know, a lot of them are pretty touchy and need a lot of extra time. This is a picture of the rehab team, primarily therapists and nurses on the inpatient unit with one of their patients. We have this emerging consciousness program. Some of our patients are with us for many, many, many months. So they get to be pretty close. This is a patient that he did not have a combat injury, but he had a stroke, and is a fairly young man, as you can see. He was aphasic, and he had a central retinal artery occlusion, lost all the vision in one eye, and it was very, very hard for him to tell us what his problems were, but through much working with him, he's made a lot of strides. This is a graph just showing sort of the etiologies of injuries that we have had. This is from 2010, 2011. You can see that we still have a lot of blast injuries, then motor vehicle, and stroke, fall, and assault. So it's actually quite a lot of blast injuries. That has really changed. I feel like there are many fewer blast injuries now. In fact, I think this is from actually the rehab people. They are CARF accredited. That was something big that happened in the last year or so. That's like a JACO accreditation for rehab hospitals, and it was a lot of work. So you can see that the number here, this was their total number of admits, and this was the total number of eye consults from 2 years ago. So things are kind of going down in terms of census. And you can see that the polytrauma and brain injury still makes up a very large portion of the patients, but stroke is beginning to take up a larger portion as well. And this is just showing much the same thing. I apologize, this slide I made Tom stick in at the last minute, but just kind of give an idea of some of the types of injuries that, or complaints that people have had, photosensitivity, blurry vision. Some of them aren't very specific, so we're going to try to work on that and get better information. This has been reported by just about everybody, many of the same complaints: convergence insufficiency, refractive error, accommodative deficits. Hemianopsia has been a big one for us lately with all of the strokes and even the head injuries. We've had really, really good luck with polyprisms, and it's been like a miracle, actually. Really has helped. And, of course, the binocular disorders as well. I think the strengths of our service is that everything is under one roof, so it's fairly easy to get people around. We don't have to drive 2 miles or 5 miles or what have you. We do have the ODMD cross coverage, so we always have somebody available. We have the availability of the low vision clinic, and having the bros as a part of the team has been really tremendous. I wish we had an OT. All of our OTs are co-treating with our bros. I think maybe they just aren't interested. We did have one who was very interested, and then she took another job, and so now she's not with us. Some of our challenges are an uneven census and the fact that the overall census is decreasing, so that in fact the inpatient ward has decreased by about 1/3, so they're reorganizing. I think we need more vision therapy providers, and we need to train them better. As Dr. Barker mentioned, I think engaging leadership is really important, because sometimes they just sort of feel like, oh, what you're doing isn't that important, or we need to spend the money on a new swimming pool, or these fancy things that have people. Have you seen for the spinal cord, whether they help them walk? Again, it's space age. It costs $2 million. So I think if we can engage leadership to the importance of polytrauma, that we'll be able to get the funding and the education that we need. And also, I think collaborating in the community is important. We have a very large brain injury center at the Hennepin County Medical Center in Minneapolis. And probably most of you know in big hospitals, the first thing that you say is, are you a veteran? Oh, you're going to the VA. But I would like to see it go both ways so that we can get some cross-communication going on that. So for future goals, I would like to get some better diagnostics, especially for doing ocular motor measurements and some more sophisticated vision therapies and doing some off-site vision therapy like we were just talking about. And Mitch, I'm really glad you brought that questionnaire because we're going to take that back and start using that for outcome measures. I think that's going to be very helpful. I have a question for everybody. Since we have this orthoptic program that we kind of work with, does anybody here have an orthoptist that works with them? As far as I know, only ophthalmologists ever have orthoptists, and they generally work in pediatrics, but they have a really good background in ocular motor dysfunction, and it seems like there would be a place for them at the VA, but I don't know at what level they would come in. Would they come in as techs or as therapists? I think part of it has to do with the way the laws are written, but does anybody have an orthoptist? All right, something we'll have to think about. Should I go on to my case study? Okay. Okay. I wanted to present this case not as evidence of what we did that was right or wrong, but just that it was unusual and to get a discussion going about a difficult situation. This is a 27-year-old Marine with a hemorrhage secondary to arteriovenous malformation of the pons, and he developed ophthalmoplegia in the nystagmus. He was stationed in California at the time, and he had most of his treatment done in Southern California, and then he relocated to Minneapolis last year. So while he was in San Diego, he went to UCSD and he received botulinum toxin for the treatment of nystagmus, and he came in asking for that in Minneapolis. And that kind of set me back because I had never done that, and I asked around, and I couldn't find anybody else who would do it. But finally, I found somebody who was willing to try it, who was not within the VA system or the university. And I thought that would be an interesting thing for us to talk about here. So, Chad, you had a arteriovenous malformation. Is that right?
Correct.
Okay. And did you have surgery on it before the bleed or after?
After, yeah. The bleed was in June, and I had surgery in September.
And that was how long ago?
2009.
Okay. And you were stationed where at that time?
In Camp Pendleton, California.
Okay. And did you have all of your medical care then at Camp Pendleton, or?
Most of it. The surgery was at St. Joseph's in Arizona, and then all my therapy and stuff was at a civilian place called Scripps.
Okay.
And then everything else was, the Navy doctors.
And when did you start having vision problems?
After the surgery in September.
Okay.
Everything was not my face, and everything was fine after the original bleed. And I went in for the surgery, and then that's when the face and everything.
Maybe tell that he had a radial palsy
And they were
on the right
trying
side.
to clip the aneurysm, or?
They were cauterizing it because
Okay.
they said it would compounded like 7% chance it'd come back every year. So yeah, they cauterized it and went in and removed the malformation.
I see. And then you had a trouble closing your right eye, correct?
Correct.
And so then you had surgery to put in a weight on your
Correct.
eyelid?
Correct.
And then later on you had that redone?
Correct. I just Originally it was a gold away
Uh-huh.
that they put in 2010, beginning of 2010. And Dr. Schmidt at Northwest Eye just replaced it with platinum, I don't know, probably 4 months ago.
So can you go ahead and close your eyes?
So you can see it still
That's
has a
very
little,
nice.
little bit of lag of
So are you
dullness there.
feel like the right eye closes well now?
For the most part.
Okay.
It's still open when I close it. It's still open just a slight that I can't even really see it, but I know at night it dries out if I don't put something in it.
Now let's talk a little bit about how your vision is affected by this nystagmus.
Okay.
You noticed that after the surgery, is that correct?
Yes.
Okay.
Yes.
And does it affect your both eyes or
Yes.
one more than the other?
Yes. It's kind of hard to say. Both eyes are affected. The right eye, I lost the side-to-side movement. I have just a little bit of up and down gaze, not very much, and I lost all natural tears in the right eye. And then the left eye, without Botox, is up and to the left, and there's rotary nystagmus, which is actually pretty, I would say it's pretty heavy nystagmus. And so,
video was done
and this eye
about
without having natural tears,
2.5
it can go
to 3
from
months
blurry
after
to,
his Botox.
I think the best I've ever had is 20/30 vision, but 10 minutes later I can have 20/60 because it's just blurry.
One of the things that people cite as a reason not to do Botox is double vision. So what has your experience been with that?
Well, before everything, I had a lazy eye, and I was kind of used to using one eye or the other versus using both eyes together. So I do get a little bit of double vision if I force myself to, but usually I just use one eye or the other because I'm just kind of used to that.
You feel like you can switch from one eye to the other?
Yes.
Good.
I mean, right now I'm looking at my right eye. I'm looking at my left eye.
I can
Right.
see that your left eye is starting to wander a bit.
Left,
Yeah.
yes.
Okay, let's get in a close-up now. So now, Chad, would you look to the right, please? And now to the left. Now how about up and then down? Okay, that's very good. And do you feel like you have much nystagmus with your right eye?
No, not too much.
Okay.
No, it's I can tell, especially when I get tired or just over exhausted. I notice it a very little bit, but not very much.
Good. Okay. Okay, so now you're looking right at the camera, correct?
Correct.
Can you-
With my left eye.
With your left eye.
Correct.
And now if you would look to the right. There we go. Okay, now to the left. Then look up. And then look down. Now look right back at the camera. Are you looking right at the camera?
Yes.
Good. All right. Can we do that one more time? To
Yep.
the right. To the left. Then up. And then down. And now straight ahead again. Okay. Now, right now, would you say in the morning that your eyelid is less droopy, or it doesn't make any difference time of day?
I would say closer to the end of the day. A couple hours before bed, around like 9-10 o'clock. Yeah, it becomes harder to keep it open.
And did those eye drops, did they help at all?
Apoclonidine that
Yeah,
I
a little
tried.
bit.
Okay.
Not very much.
Sometimes helps for
don't think
broncho
so.
spasm when they get ptosis, but
All
it didn't
right.
really help him.
Thank you.
So, Dr. Hurdle, do you want to give me your opinions?
It's really complicated because he's 3 months outside of Botox. So the left
Yeah.
eye is a combination of brain disease and Botox.
Right.
He doesn't have much nystagmus in the right eye. It's because probably this is an acquired penduliform, which is multiplanar, and the horizontal component's knocked out by the by the 1.5 syndrome or the complete gaze paresis. I don't know if he has a 1.5 or not, because again, he's Botoxed on the left, but he clearly has a gaze paresis on the right, which is knocking out all horizontal movement, including the involuntary ocular oscillation. He's really lucky at childhood strabismus so that he can alternately fixate,
It
because
actually is.
he would have, the interesting thing is that the biggest complaint of patients with acquired involuntary ocular oscillations, not saccadic though, saccadic they suppress, is oscillopsia. So I think that one of the questions are, because oscillopsia is as devastating and debilitating to patients as diplopia. Chronic diplopia causes people to become suicidally depressed. If you've ever been around someone who has untreated diplopia, you can cover one eye and help. But oscillopsia is the same thing. And oscillopsia you may not be able to get rid of. These people are miserable. They would rather be blind by the end if they can't get relief from the oscillopsia. So the shaking of the world is as important a symptom as any other visual symptom with acquired ocular oscillations. This is a very complicated case, and it's hard to tell because he's been treated, but I'll just talk a little bit about the medical treatment of nystagmus. There's a bunch of medications that can help acquired forms of nystagmus that may be as good if, yeah, there we go, okay. And actually some of them are bulleted, so 3,4-diaminopyridine, which is not the one that's used now, it's called Ampyra or dalfampramine, and it's great for upbeat and downbeat. Baclofen is beautiful for PAN, and it sounds like
He's already taking baclofen.
He's on baclofen.
It's not helping him that much.
Right, so the reason that you can't know which medicine's helping him is because the most important thing for him, and you may not have this, has not been done. So I'll give you the analogy. If I go to my car to someone and I'm saying I'm in chest pain, I'm having chest pain, and you go in the ER, what's one of the first things they do for you?
EKG.
Right.
Yeah.
So my eyes are wiggling, so I'm not going to measure it. Why should I measure it? I know you have nystagmus. Well, there's 50 types of nystagmus. They're all due to different brain diseases. They all have different targeted treatments. So why don't we get eye movement recordings and see which one it is? Because acquired pendular nystagmus is exquisitely sensitive to memantine or Namenda. I don't see that up. Oh, there it is, memantine.
Yeah, it's in the middle
So
there.
what you can do, well, I don't have eye movement recording, so let's start with A, acetaminophen, and then just start him on, and then we'll go to barbiturates, and then C, we'll go get him to smoke some pot, and then D, what's D up there? We could just go through the
Alcohol.
list and see which one fits, and then, I mean, that's the way sometimes it's done.
Yeah.
I mean, that's why maybe he's tried all these medications, I don't know. But it's a much more targeted treatment. So if you can treat acquired nystagmus with oral medications, and we're actually finding some benefit to topical meds, we're experimenting with some new topical medications that may also work on the enthesial nerve endings and regulate how the brain controls the eyes. But as far as Botox goes, so there's a lot of people that try Botox, 25 units in the orbit. It's a neuromuscular paralyzing agent, and it will stop the nystagmus. Unfortunately, it stops everything else. And the most symptomatic these patients are not only from the diplopia, but from the absence of the VOR. So the real indication, I've seen a lot of patients with this, and the only ones that work on any chronic basis are a monocular patient, basically wheelchair bound, that doesn't want to do anything but sit around and watch TV. If you try and use Botox, they will be effective for about a week or two period during the course of 3 months when the medication is perfectly the right amount, as either it's wearing on or wearing off. So it's really not a great treatment for them. And in only those situations in which the patient either agrees to be monocular, so that you'll cover one eye and inject the other, and has tried everything else and is so depressed that's the only situation that I use it. I don't think it's really a good first-line treatment. It's
agree.
not a targeted treatment for it. I think some of the medications are helpful, and there's actually some surgical procedures that will help acquired pendular nystagmus too, if this is acquired pendular or multiplanar.
Right. What would you recommend if you were? I don't think he'll consent to do that, but
To do what?
to do surgery.
Right. He's not yet.
Yeah.
He may not be depressed
Yeah.
enough yet. Some people, really, I'm telling you, some people get so desperate and they want to do something.
He's such a cheerful person. I mean, I think the fact that this was a stroke and not a TBI, he's not PTSD. He seems to just kind of roll with the punches, and it's kind of unusual.
I would recommend eye movement recordings to diagnose his
Yeah.
nystagmus type. But if
We're going to
can't,
do that. We just
Good.
have been kind of challenged. We can get it in our physical therapy with our audiologist, but we haven't done it yet. So
Right.
I think that would be
yeah,
very
well,
helpful.
I think that will help.
Yeah.
And then you can do some targeted treatment based on that. And that's easy. You can just look that up. You know, say you find out it's acquired pendular nystagmus, then you look up the treatments for that and try it with someone else.
But I think you're right. If you look at the recommendations of Eugene Halveston, he says, you know, only one eye should be treated, and a typical patient has a brainstem stroke and is basically monocular, which he kind of basically is because has strabismus and amblyopia. And
the other interesting thing that he said, and it's very important if you listen to patients, they'll tell you stuff, is he said he didn't have the nystagmus problem until they did the surgery. So he's blaming the surgery on the nystagmus, rather than being grateful that the surgery saved his life.
Right.
He has a side effect of the surgery, and this is very common with surgical treatment. So if you come out different than you went in with surgery, even though the goal was met, a side effect or brain surgery often involves there's some defects that are created, especially with brain stem and posterior. So the interesting thing is to try and get to that in the patient, because I find that if there's some resentments about some of the treatments, then it makes the patient, and he is a cheerful guy, it seems like that, but there's a resistance to try our other suggestions. So we have to overcome some of those. So I got a sense that somehow he blamed the surgery, not necessarily the surgeon, although sometimes that goes hand in hand.
I hadn't heard that before, so I thought that was kind of interesting.
Yeah, and patients will often say that, well, it was the surgery that did it. And he's right. It is a complication, but that's not the way he phrased it. You know?
Right. Yeah. So those are the drugs, again, that have been tried. Actually, so far he's only tried gabapentin, which he didn't tolerate, and baclofen. So I'm going to be working with his doctor to try some of these other options for him. Here's just a few of the side effects, and I think that's probably pretty much across the board: drowsiness, dizziness, lethargy, drowsiness, dizziness, lethargy. So those are problems that, you know, in terms of him as a young man, he doesn't want to feel like he is just being zoned out for the rest of his life. So try to find something that he can tolerate a little bit better.
I've got a few comments. Usually, first of all, these are due to cavernomas, which are venous malformations, and usually they should not be treated surgically, because as many people have found, what's happened to him is that the complications of treating them are worse than the risk of rebleeding. Even if they do rebleed, they usually resolve with time. They're usually not fatal. There are sometimes exceptions, but anyway, that's one aspect. The other aspect I'm really concerned about with this patient is his cornea, because usually fifth nerve is involved here too. They have a problem with neurotrophic cornea. As you could see, even though he could voluntarily close his eye while he's sitting upright, he doesn't have any blink. And there's a lot of movement now in terms of microsurgical transplantation of the facial nerve branches from the other side into the affected side, so that there's a concerted, more normalized blink. And he would be probably a very good candidate for that, not only for restoring his blinking, but his facial movement on the right side. And the reason why gold weights aren't very good in this setting is that they depend on gravity to work. And guess what happens when he's lying flat sleeping? Doesn't do anything for him. And so he's going to get into trouble long term with his cornea. So that's something I think needs to be addressed, because that's going to be a long-term problem that's going to limit his vision in the right eye eventually, I think. I agree with the comment about needing to characterize a nystagmus. Now, let's say you don't have anybody who does recording. After the Botox wears off, you can do a good video of both eyes in the picture at the same time. And most of the time, if you send that around, most people can diagnose what type of nystagmus it is in primary gaze, and have them hold positions of gaze more to see what's happening, not just quickly. And I think most neuro-ophthalmologists, most eye movement experts would be able to help you make the diagnosis even without formal eye movement recordings if you had good videos. It has to be both eyes at the same time in the picture, though. And I agree that some of these medications, mainly gabapentin and memantine, can be very effective, but the doses have to be pushed pretty high, and you have to do this in concert with someone who's used to administering these doses. Most of the patients that this applies to are usually MS patients that have these types of nystagmus that are debilitating. And most neurologists that treat MS patients are pretty well versed in using these medications. So I think that's mainly what I have to say.
Thank you.
Just kind of quick anecdotal comment about the Botox, not to belabor the topic, but I've come across 2 patients that every time I hear about Botox being used with the acquired nystagmus, they just come to mind because they sat in tears with me as I was seeing them for the first time, because they were patients that had suffered AVM ruptures and had a multitude of deficits, but they had been seen by people who hadn't fully understood all of their deficits, and they kind of heard, oh, I can use Botox for nystagmus treatment without really thinking about consequences and how to do it. They certainly sound like they weren't trained in the area. The patients were actually binocular with good acuity in both eyes prior to being Botoxed bilaterally. Both of these patients were.
Bilaterally?
And so they had frozen eyes. As it was wearing off asymmetrically. So, of course, then they had severely non-comitant strabismus. And they said what was supposed to help me and make me better made my life worse than I could ever imagine. And they said, if you come across patients that ever mention this, tell them never, ever to do it. Now, on patients who are monocular, it makes much more sense because we don't have that issue. And your patient, again, as was pointed out, is very lucky that he had the childhood strabismus, so he can switch fixation. But I just thought I'd share it because that always left a big impression on me from those patients. And just to think about whose hands they're getting into and taking treatments that you've heard about but not really investigated and thought about.
I agree.
I don't want to say this if you're going to talk about it. Are you going to talk about the rehab treatment of this fellow? Or
No.
is this, okay,
Go
well,
ahead.
my thought on the rehab end is for the acquired nystagmus, I think that people sort of think all we can do are these other interventions, but from a rehab standpoint, magnification is great. CCTVs allow these people to read because the fixations are really erratic. But if you blow the print up, that's okay. They can do that. Magnification in a telescopic system may be more difficult because everything's, really moving more rapidly. But from the standpoint of closed circuit televisions and a primary gaze, that can be a wonderful way to get them to go back to reading. I had a little young lady with a very severe injury and oscillopsy that was really different in each eye. And she could read the funny papers again, and it just, was a joyful thing to watch her doing that. But I think that's something that needs to be thought about with these cases that, there is some rehabilitative intervention that can be done.
He hasn't really complained that much about his vision.
Yeah, 'cause
it's kind of interesting.
That is, because I would think even though he's 20/30 at distance, at near,
Right.
he'd start to run into trouble with that movement. So
But that, I will definitely bring that up.
Great.
Yeah, thank you.
I forgot one more treatment for acquired oscillopsia that you all may be more familiar with, and it's retinal image stabilization. We started this a long time ago, and when I was a fellow in the 80s at the lab in the VA. And you put a high minus contact lens on the patient. What we were using was a 32 lens, minus 32 lens with a aphakic spectacle type on the front. But I've actually done this in the office and put a minus 15 or 18 on the patient and then over-refracted them with a 4-opter. And you can actually get 60 to 70% retinal image stabilization with this, and the patients will see much better. So you can try this. There's a bunch of literature on this. Stacy Naglos at the VA in Cleveland has continued to do some of this work, and there's actually a machine that will do it. And you can do it monocularly. Can't really do it binocularly, but it does help. It does help some patients, but it's a bit laborious to do it. So you can try it.
Great. Now we have lots of options. Well, thanks, everybody.
We got one more. Your idea of using orthoptists. In Hawaii, our options for referral are limited by time and money.
Yes,
and
I'm sure they are.
Oh, yeah. And all the veterans in American Samoa, they have a 5 or 6 hour flight just to get to Honolulu. And if we tell them that they've got to go further to California, that's a big problem. So
That is a big problem.
So having somebody that's already knows the visual system and the pathways would be very helpful. But I think there's a huge HR issue in that.
I think that's the problem,
Yeah.
and I haven't figured that out yet.
That's very nice, Ann. I'd like to address 2 of the issues that you raised. The first one, you made the point that this is a good time to make your chief of staff or your leadership aware of what you're doing. And I have to say there's never been a better time, because I think the ophthalmologists in the room know that starting 1 October, which is about 5 weeks from now, we're going to be held to productivity standards, along with 5 other specialties. And some of those other specialties deal with polytrauma just as we do, because neurology is involved in orthopedics and urology, as well as dermatology. But the point is that the time is going to be strictly controlled, and there's labor maps that the ophthalmologist should have received now where you have to map out your time, because what they're trying to do is figure out how much clinical time you should have. So the point is to take away all the other justified time, whether it's administrative, if you're a committee chair, at the VA or at the medical school or on a national level, and there's guidelines for how much time you can deduct for that. Also for research, if you have at least an IRB-approved research project. Now, if you don't have an IRB-approved research project, it could still work, but you have to get your chief of staff to allow you the time. And so the point is that after all that, you have some clinical time. Now, there's no distinction between what you do as a clinician for an ophthalmologist. And John Townsend's aware that this is going to be coming a year or two for optometry, too. Optometry's been added starting in this next fiscal year in 5 weeks to the grid. We have a national database that shows all the facilities by complexity level, all the eye care providers by name, and it's going to show their work RVUs, which is going to be the measurement that's used to generate your productivity report, and your FTEs at the bottom. So the FTE is determined by your labor map. So the point is that if you're a neuro-ophthalmologist or if you're in vision rehab, those are the two that have been identified as probably not getting enough credit for your work time. So you're going to have longer examination times. And that's come up, and it's been a point of contention as we worked with the task force for the last 6 months, particularly for those two, of which you all are. And the only answer is that the chief of staff has to allow you the time, going through your section chief and the chief of whatever your service is, whether it's surgery or wherever you wind up under ambulatory care or whatever. But the point is there will probably have to be an exception made at your local facility to allow you the time to do these exams. So now is the time to make your long-winded story. Now is the time to make your leadership aware of what you do and how much effort is required for the polytrauma patient. And theoretically, we'll get more polytrauma patients as the ACA goes into effect and people can choose the VA for their medical care and as the troops come home from overseas. So I can only see the workload increasing. So this is very critical now that you get on the screen, your radar screen for your local leadership to identify that you need extra time because if they're not aware that the way it's going to work is starting October 1st, if you're either below 25th percentile of the mean for the whole field across the VA, for instance, let's say ophthalmology, if you're seeing less than 25% or more than 75%, it comes to the chief of staff's attention. If you're one standard deviation below the national mean, then they have to come up with an action plan at your facility about how to improve it. So they're going to be under the gun. So they're going to be coming to you in a panic and saying why you're not seeing the required number of patients based on your FTE. So I'm just throwing this out there. Now's the time to think about it. You have a few more weeks. Another issue you mentioned was orthoptist. John and I are both working. We have 2 groups working on a conversion of our ophthalmology and optometry technicians from Title V to hybrid Title 38, which will allow us to give them more money and hopefully help recruitment and retention. And we've discussed the medical technicians that we have, eye technicians. We've discussed the medical instrument technicians. We've discussed eye photographers. But to my knowledge, at least in the ophthalmology work group, we haven't discussed orthoptists. Have you done that in the optometry work group? So I don't know the answer to that. We can bring it up at the next meeting, but we haven't discussed it so far.
No, we really haven't brought that up yet, but a lot of the times you can have very broad responsibilities that your ophthalmic techs can do, whether they're optometry or ophthalmology techs, dependent upon your need. Also for optometry, when we do this mapping where you look at the clinical time, the research time, educational sorts of things, the admin sort of things that you do, we do have categories within optometry such as your low vision optometrist. make sure that you have that as your title, because we'll be able to pull that out. And when I looked at productivity briefly, all those sites with blind rehab centers where you had low vision optometrists doing very labor-intensive sorts of things, they all came low. And it's an obvious thing, and it's something that we're working with, VA central office. They're aware of this. The same sort of thing can happen if you're doing a lot of teleretinal reading. There is no category for that. So this is also something in evolution, and they're also trying to make sure that when they do look at the productivity, they're looking at only the clinical time that you're supposed to be doing clinical activities. So as we work through this, and as Glenn had mentioned, all the other specialties will be getting involved with this, and he's in ophthalmology at the forefront of that.
That's great.
Yeah,
Thank you.
I think it's probably, like you say, it's fairly obvious for the low vision clinics and so forth that are neuro-ophthalmology, although I know you do a very quick neuro-ophthalmology exam. I've heard it said that an average neuro-ophthalmology exam takes 2 hours. I don't think so, but hopefully not. But it won't be so obvious in the general ophthalmology clinic, for instance, if you're having polytrauma patients coming in and the residents and the general ophthalmologist are working with the polytrauma patient in the wheelchair. So I can see that having lived this for many years, I can see that taking a lot of time. So just something to be aware of.
Thank you.
Good luck.